So I think the newest entrant in our toolbox has been the advent and the subsequent approval of CD20 bispecific T-cell engagers, namely glofitamab and epcoritamab. Recently, the FDA approved glofitamab and epcoritamab in the third-line setting in patients with relapsed refractory diffuse large B-cell lymphoma. So that obviously poses a very important question in the field, because CD19 CAR T-cell therapy, especially axi-cell, lyso-cell, tisa-cell, have all been approved in the third-line setting as well. So how does one choose? How does one sequence? I will say, I think usually the long-term follow-up is what we go by. So when you look at the long-term follow-up of the CD19 cell therapy products, we do know that in the third-line setting, it can actually salvage and cure about 40% of patients with relapsed refractory large B-cell lymphoma. That kind of follow-up we just don't have yet, so we'll have to wait it out in terms of the bispecific T-cell engagers. There is good data to suggest in all of the bispecific trials, about 1/3 of patients had prior CAR T-cell therapy, and the response rates in patients who had or did not receive CAR T was actually similar. On the other hand, the reverse, there is obviously the concern of T-cell exhaustion, so giving a bispecific prior to CAR T-cell therapy poses a little bit of doubt. So with regards to sequencing, in my opinion, I go for something that's more curative, that has a higher degree of long-term follow-up, and with regards to sequencing, because of the concern for T-cell exhaustion, I usually select a CD19 CAR T-cell therapy over a bispec. I think there are some other issues that also need to be sorted with regards to efficacy in CD20 bispecific T-cell engaging products. For example, established CNS efficacy has been proven in CAR T-cell therapy. It is technically not known to be there for CD20 bispecs, although there was anecdotal data from a retrospective cohort with glofitamab. There's also the issue of CD20 expression. When you look at bispecific T-cell engaging antibody responses, the responses are a lot higher if you have a CD20 CD20 expression on tumor cells, versus it's attenuated if the CD20 expression is not there. So overall, I will say that if cost and logistics aside, I would usually choose a CD19 CAR T-cell therapy product over a CD20 bispecific T-cell engager. But I also believe that this debate is not going to be lasting for too long, because both of these products are being tested in earlier line settings. There's the distinct advantage of bispecific T-cell engagers with regards to its off-the-shelf availability, as well as decreased cost as a result. There's no need to wait to get the manufacturing done. As a result, there's no need for bridging chemotherapy. The lower doses are effective. So they certainly come with their shared pool of the good things. But at least for now, until more trials come out, my option, my choice would be CD19 CAR T-cell therapy over CD20 BiTE.